And so from an editor's viewpoint, I'm the associate editor for CCI, so I picked a few articles, not just CCI articles, that I think we all need to be familiar with. I want to start with a quick case. 54-year-old female, diabetes, presents with a focal right third toe plantar ulceration. She undergoes ABI assessment by an outside physician, but at that time has no referral for further invasive therapy for about 3 months, has some local debridement, osteomyelitis develops. And if you look at her ABIs, what do you notice? That they look pretty normal. Does the patient actually have significant PAD? And as we've seen, we have to look further, and the digital toe brachial indices are abnormal. So when we actually do an angiogram, she really has no inflow or tibial disease and has a diseased pedal plantar loop, as you can see, diffuse disease, undergoes successful angioplasty, and then is able to heal her amputation. And so what this really points to is the fact that the ABI is a very crude test, and particularly in critical limb ischemia, we have to be careful with it. So our goals in revascularization are really angiographic improvement in the lab, where we want to improve blood flow ideally to the angiosome in question, or if you can't, globally to the entire foot, and then have some degree of durability, at least long enough so that we can get proper wound care and have the ulcer heal. Of these, number one is really the key for endovascular operators, because we don't want them to leave the lab with a suboptimal hemodynamic result. So hemodynamic assessments involve baseline assessment, post-procedure, and serial longitudinal time points to be able to follow these patients over their clinic visits. A wide variety of different tests. You've heard a lot about these different ones: ABI, toe brachial, duplex, transcutaneous oximetry, various forms of non-invasive angiography, and then sort of the good old physical exam, which has obvious limitations. There's quite a few deficiencies in the literature in that most of the guidelines recommend the use of ABIs and ankle pressures in patients with PAD, and these data are largely derived from claudicants. And so the utility of these measures in critical limb ischemia is still very poorly understood. In claudicants, you saw earlier a change of about 0.15 has been associated with improved outcomes, but whether that applies to CLI or not is still uncertain. And the derivation of the toe brachial index. We hold gospel that 0.7 is some kind of magical number, but if you go back and survey the literature and understand where that 0.7 came from, you'll see that it's not really derived from a CLI population. So here are the 4 articles that I felt were most relevant from 2017 to 2018 in the context of hemodynamic assessment. One's out of the University of Michigan group, 2 are from Mehdi Shishebor's group, and one is in fact in collaboration with my fellow Tarek, who's here. And one is an interesting proof of concept study out of Hungary that we'll briefly touch upon. So the first study is from Michael Grossman's group at Ann Arbor, 10,000 patients undergoing endovascular or surgical revascularization. They surveyed the Blue Cross Blue Shield registry in Michigan, and their goal was basically very simple: to describe the distribution of ABIs in a CLI population. And what you see here is the distribution of ABIs by patients undergoing PVI, which I highlighted in blue, and surgery, which is the lighter line, and patients undergoing peripheral vascular interventions that higher ABIs than surgical, but that's not the relevant point. It's more that you see a bell-shaped distribution of ABIs across the CLI population. So it's not necessarily skewed towards low ABIs. When you actually break it down, and so when you look at categories of normal ABI, mild to moderate, or severe, you see that normal ABIs are about 20 to 25%, mild to moderate 50 to 60, and severe 14 to 20. So this really tells you that the vast majority of people in this large series have normal or mildly impaired ABIs, despite having critical limb ischemia. And only 20% of patients in their cohort actually had toe brachial pressures even measured. So at least one interesting finding was, regardless of the ABI, revascularization improved quality of life and function. So there is this disconnect between these indices and the response to revascularization. So once we assess them at baseline, we want to be able to follow these patients longitudinally. So how do we assess hemodynamics post-revascularization? And that's what Dr. Shishebor's group looked at. They had an observational study, 218 patients undergoing endovascular therapy for CLI. They looked at pre and post indices and examined this in the context of wound healing and major adverse limb events. Again, you see a distribution of ABI in the population, and after revascularization, an increase in ABI. Similarly, in TBI, it improves after revascularization therapy. We saw these data earlier, so I won't spend too much time on it, but understanding that they found an ABI increase of 0.23 was associated with improved wound healing, and a TBI increase of 0.21 was associated with increased probability of wound healing. So again, as we heard, small sample size, but still important signal that our traditional definitions of 0.15 in claudicants may not apply to CLI. So when we further look at this is Mehdi and Dr. Hamad's work looking at the Impact Deep trial, and they looked at 358 patients from this study, and they looked at ankle and toe pressures. So as opposed to just ABIs, looking at absolute ankle and toe pressures, and the response to endovascular therapy in the change in these measures, and the association with outcomes. And when they used receiver operating curves with male or major adverse limb events as an endpoint, they found a cutoff of a change of 73 or a change of 1 millimeter for toe pressure to be significant. The AUCs are relatively modest, 0.51 and 0.64, and that's reflected in the male-free survival, where if you had an improvement of more than 73 millimeters of mercury in your ankle pressure, there was some thought, or some trend that there was a benefit, but did not reach statistical significance. However, with toe pressures, if you increased it by 1, there was a benefit with respect to probability of healing. So what this tells us is absolute changes are small in toe pressures, but they may be relevant, and perhaps absolute ankle pressures alone are less helpful. So maybe taking it into account with a ABI change or TBI change is more helpful. So finally, when we're in the lab itself and we're trying to make treatment decisions, as opposed to the coronary circulation where we can do a variety of different techniques to understand whether we've treated a lesion successfully, we're limited. So in this study out of Hungary, they considered the use of invasive measurements using principles of pressure gradients and FFR to help predict outcomes in patients with CLI. Again, very small study, but I think important to understand as a proof of concept. About 39 patients, they looked at resting gradients, FFR measurements, correlated those with non-invasive parameters. They used a pressure wire. They used hyperemia with papaverin, 40 milligrams injected into the artery, and they had clinical angiographic follow-up. An example from their report is here. Here's the anterior tibial artery, and you can see diffuse disease before a FFR of 0.66, and after therapy, that increases to 0.83. I want you to note here, look at their perineal artery, which has been untouched, which is still diseased, and we'll come back to that in a second. When they correlated these invasive hemodynamic measurements with transcutaneous oximetry, toe pressures, and perfusion indices, the correlations were relatively weak. However, baseline FFR had the strongest correlation with baseline measures of perfusion, including toe pressure. So here's the response in gradients before and after angioplasty. You can see they demonstrated a decline in pressure gradient, a improvement in the translesional resting ratio, and improvement in FFR. But the gradients in FFR improved but did not normalize post-intervention. And I think part of this is also the fact that if you don't assess the distal vascular bed, that's going to be a problem. Completeness of revascularization is important as well, which was not entertained in this study. When they looked at the correlations and with respect to major adverse events, the FFR value of more than 0.66 had the best cutoff value to prevent freedom from MACE. And they also measured something called an FFR wedge pressure, where they actually inflated a balloon on the FFR wire and got a distal wedge pressure, which has relevance in the context of collaterals. They found that people who had a lower wedge pressure underwent more amputations, very small sample size. But again, this is a very important first study in this context. So take-home points, the ideal non-invasive measurement in CLI is still unclear. It appears that changes in measurements are more helpful than absolute static measures, and that these changes can be looked at in terms of associations with improvements in symptoms, but that's still relatively new ground for CLI. And I think there is a role for FFR in invasive hemodynamics, but that's still uncertain. Thank you.